So today's class is on nephrology, taken by Dr. Sangshaptak Saha. So sir, I hand over the class to you. You can begin the class.
So we shall be discussing around 40 questions today. It's not on any particular part of nephrology. It's a mixed bunch. Since the last class, so no, the questions not very difficult, but yeah, a few questions are there which will intrigue your thoughts. So let's start. As usual, we shall give you like 1 minute to read the question, and then we shall discuss. If you want, you can write down the options in the chat which you think is right, and we shall see who was right after this discussion. Okay, first 2-3 questions I shall also read with you guys. So 40-year-old man presents to the renal clinic with long-standing CKD. He is suffering from associated metabolic bone disease, and the GP has asked for an explanation of the cause and features of metabolic bone disease. So it's basically the changes in phosphate, calcium, and vitamin D which happens in CKD. So just few of you can just write down your answers in the chat box, and we shall discuss after 30 seconds. So let's see whether anybody have written anything or not. Option D, yeah. So let's rule it out one by one. I think everybody knows that in chronic kidney disease, there is some issue with the phosphorus and the calcium, right? So what happens with the phosphorus is that the phosphorus excretion is decreased. So immediately option C and option E becomes wrong. Phosphate excretion not increased. In fact, we have to use some drugs like phosphobinder or sevelamer to help in the phosphate excretion. So phosphate excretion is decreased. So that is only option D is there, and parathyroid hormone levels are increased, and the vitamin D active form levels are decreased. So they have not mentioned the calcium. What happens is that phosphate level is increased. Okay, here they mentioned phosphate excretion, which is decreased, which is the right option. So phosphate level is increased, calcium level is decreased. That results in stimulation of parathormone. So parathormone levels are increased. But the increase in the parathormone levels, that is usually insufficient to make up for the low calcium. So calcium levels remain decreased. This is called secondary hyperparathyroidism. Because the hyperparathyroidism is occurring because secondary to this another cause, which is CKD in this case. And 125 hydroxy vitamin D levels are decreased. Why? Because this level, active form of this 125 dihydroxy vitamin D, that is formed in the kidney. One hydroxylation occurs in the lungs, the dual hydroxylation occurs in the kidneys. That is why the level is decreased, because obviously the kidney is not functioning. So that was question number 1. I hope this part is clear. Biochemical changes in kidney disease, metabolic bone dynamic changes, osteoarthritis, fibrosis, cystic, these are all typical questions in MRCP, both parts. In the past 2 parts, we have discussed about on-exam and mostly past test. These questions are mostly from past medicine, and few questions are past test. All are of the last year's or this year's edition, 2023 November or 2024 edition. So the latest questions. So second question is peritoneal dialysis with type 2 diabetes, admitted with fractured neck of femur. His serum calcium concentration is 2.9, phosphate is 2.2. I hope you guys know what a normal level of phosphate is. And in the actual question, they will usually provide you the normal levels. And the parathormone level is 0.4, which is low. Medications include alpha calcitriol, a typical therapy in type 2 in the chronic kidney disease, and they are also supplementing the patient with calcium carbonate. So the question is, what would a bone biopsy show? And they have given both adynamic bone disease and osteoarthritis fibrosis cystica in the options. I think we all know that it will not be increasing the plasma cells or aluminum deposition in the osteoid bone interface, right? So the options are between A, C, and E. The patient does have a history of fractured neck femur. As usual, 30 seconds, and then we shall discuss. Write down your answers.
So once again, show the question, sir. Sorry.
So let's see what answers you have given. You can also open your mic and tell me. Anyway, you have written everything here only. So it's a mixed bag as expected. It's A, E, A, C, E. Somewhere even option C. Option C, doctor, I think is the increase in plasma cells. Increase in plasma cells is not the answer. I can tell you straight away. Increase in the plasma cells is not related with the condition. Okay. increase in plasma cells will not be the answer here. It's unrelated to the question. So option A and option E, and one Dr. Amino Farah has given option D. Okay. So why do you think it is adynamic bone? Firstly, what is adynamic bone disease and what is osteolytic fibrosis cystica? And how do you diagnose osteolytic fibrosis cystica? If you know that, then the question becomes much easier. Because osteolytic fibrosis cystica cannot be diagnosed by these metabolic parameters. It needs a, at least an X-ray of the bone. Okay. Osteolytic fibrosis cystica is a brown tumor, right? I think everybody knows that. It's commonly comes in MRCP as a brown tumor around the bone, or it comes as what it is known as like that. So for osteolytic fibrosis cystica is not involved with these metabolic parameters. It is something which is a tumor in the bone, and it can be associated with rheumatological diseases, not with the CKD. So I think now everybody knows that this option A, it is adynamic bone disease, which by definition needs a low parathormone, which is given here. Parathormone is 0.4, phosphate is also low, and calcium concentration is high. So calcium is high, phosphate is low, parathormone is low. So despite the low parathormone, calcium is still high. Because the calcium is high, parathormone level by the negative feedback loop has decreased. But because of wastage of bone, loss of bone, so calcium is still high. That is the clue. Okay. Chronic kidney disease patient, this is typical adynamic bone disease is classically associated with CKD. So the answer is adynamic bone disease.
So what is adynamic bone disease? I didn't
Adynamic bone disease is a condition where the bone tissue does not renew itself as it should. Okay. Okay. Because bone is a dynamic thing. There is calcium deposition, there is loss of calcium. Net result is the calcium which is present in the bone that is maintained. In adynamic bone disease, what happens is the serum calcium concentration, as you can see, is high. So there are only two causes of serum calcium rise. Either the parathormone level is increased or the calcium is coming from some other source, like a malignancy, like from bones, like it is not excreted properly. So excretion of the calcium is not mentioned here, so you will not consider that. Here parathormone level, they have told it is low, and the patient is on peritoneal dialysis. So there is a problem. So obviously the patient is a CKD patient. So that is why the calcium is high, because the bones, from the layers of the bones, the calcium is coming out. There is osteoporosis, and they have given the name fractured neck femur as a hint. There is osteomalacia, osteoporosis, as a result of which calcium level is high.
So then why the option E is not correct?
Option A is correct, right? Adynamic
E. Osteoporosis.
Yeah, but only osteoporosis will not explain the parathormone level is low also, right? Only osteoporosis will not explain that. And the patient is a CKD patient, and like adynamic bone disease fulfills everything. See, the patient is peritoneal. If you come from the first line, peritoneal dialysis patient, CKD patient, fractured neck of femur. So there is some problem with the bones, osteomalacia, osteoporosis, something like that is there. Calcium is high, phosphate is low, parathormone level is low, and he's on some medications. So adynamic bone disease fits this thing more than osteoporosis, because the fracture neck of femur can be because of osteoporosis, can be because of osteomalacia as well, right? Osteoporosis.
So, one doubt. Usually in CKD there will be secondary hyperparathyroidism, right?
Yes.
So, but why the parathyroid hormone is low here?
That is called tertiary hyperparathyroidism. That is advanced CKD, and the secondary hyperparathyroidism occurs in early CKD or in medium CKD, where the parathormone level is high because the calcium level is low. Okay, like we discussed here, the first question, option D, they are not mentioned the calcium level, but here phosphate will be high, calcium will be low, and because of the calcium is low, the parathormone levels will be increased. Here, because of the adynamic bone disease, which is not like every CKD patient doesn't have adynamic bone disease, right? Here, because of the adynamic bone disease level, despite the CKD, the calcium level is high and the parathormone level is low. That is why it is not only a CKD patient. It is a CKD patient who has developed this adynamic bone disease. I hope I think,
Okay.
I don't think I am very clear, but the CKD and adenemic bone disease are not like, it's not like in every CKD patient will have this adenemic bone disease. Okay. It's a condition which is associated with CKD, sometimes adenemic, sometimes with advanced CKD. Adenemic bone disease can occur in many other conditions as well. CKD is the most common, the others are relatively much rare conditions. Okay. So the third question is, a 45-year-old man on lithium for bipolar disorder developed a heart failure 2 weeks back. He now presents with drowsiness, nausea, vomiting, blood vision, post tremors. Which one of the following concurrent medications, if taken in combination with lithium, will be the most likely to cause these symptoms? There's nothing much to think in this question. It's just a question which has come multiple times, so I have included it here. Yeah, somebody has already mentioned, Dr. Mochumi has already mentioned this option C. Option C is
Sir, can you show this?
Yeah, sure. Option C is hydrochlorothiazide. I can wait for 30 seconds for the others to come up with some other options. Then we shall discuss of this. Okay. Anybody else thinks it's hydrochlorothiazide? Yeah, everybody thinks it's hydrochlorothiazide, so everybody knows the answer, and that is hydrochlorothiazide is the one which acts with lithium. I mean, which drug reaction occurs with lithium, resulting in excess lithium levels and hence the post tremors and nausea vomiting. Other diuretics don't interact that much with lithium. The thiazide diuretics will be the answer. Let's go through the question. It's long stem. 82-year-old man, orthopedic ward, 1 week after surgery of femur, heart failure, furosemide, no other significant medical history. So he's an elderly person who has got a neck femur fracture, and he also has a heart failure. He is on medications of Lasix. Post-operative recovery, however, he developed urosepsis due to gentamicin. So he is on Lasix, he is on gentamicin. Both are nephrotoxic. I hope everybody knows that Lasix is a nephrotoxic drug, right? Lasix we give to increase not good, but Lasix is not good for kidney. It increases lactate, increases urea, increases creatine. It does every bad thing possible for the kidney. Yeah. So surgeons notice that a serum concentration is 350. On examination, the patient is euvolemic. So he is not fluid depleted. Because why they have mentioned euvolemic? Because the patient is on furosemide, he is an elderly person after heart failure. After the femur fracture repair, and he has developed a sepsis. So they are specifically mentioned that he is euvolemic, which will be helpful to reach the diagnosis. Urinary sodium they have given, urinary osmolality they have given. I think everybody has gone through the stem by now. So which is the correct answer here? Everybody has answered option B, I think. Gentamicin meant the question easy, right? Gentamicin, the answer is always acute tubular necrosis. Anyway, oh yeah, the answer is obviously acute tubular necrosis. So find out the other options. Acute septicemia. Acute septicemia, okay. His urine sodium is 48, which is higher side. Urine osmolality is 320. Acute septicemia will not cause this much since he is euvolemic, BP is okay, afebrile, so also acute septicemia. Chronic kidney disease, he does not have chronic kidney disease. They have clearly mentioned no other significant past medical history. So that rules it out. Post-renal AKI. Why do you think it is a post-renal AKI? Because there is no mentioning of any obstruction. So that is ruled out. Finally, pre-renal. They have mentioned euvolemic, so it is not pre-renal. That leads to acute tubular necrosis. And obviously, you guys are prepared well and you already knew the gentamicin and you made out the diagnosis. So yeah. Moving on. 26-year-old man registered to the new GP and is noticed to have non-visible hematuria. Referred here. There is a history of deafness. I think you guys will know immediately know the answer here. Deafness with a kidney disease question has only one answer. Yeah.
Alports.
Yeah. So yeah, let's not waste the time here. The creatinine is high. There is a history of deafness, and they have given the usual things. The parents are divorced, and there is no family history available. Everything, because Alports always has a family history. And so, what is the most likely diagnosis? It is Alports. We have two other questions related to Alports today. we shall discuss the underlying cause and those things later. Okay. A 72-year-old bipolar patient is seen in the renal new patient clinic complaining of thirst for 6 weeks. So bipolar patient, 6 weeks complaining thirst. He is not a CKD patient. His urea is okay, it's high. It's almost 3 times the normal. Creatinine is just increased. So you can immediately see that it is, it's not too bad, right? Urea is not too bad. Creatinine is not too bad. Sodium is just high. Urine osmolality is low. Urine osmolality is low. So these are the options. A bipolar patient, that is I think everybody knows what the bipolar disease is, right? Their patients are psychiatric patients. They are under some treatment of the psychiatrist, and they are presented with clinical scenario.
Is it nephrogenic diabetes? Sorry.
Yeah, I can just wait for the others to answer or reply in the chat box. Is somebody else also reply in the chat box, and then we shall discuss after 30 seconds. We shall have a good discussion here because there are 2-3 topics that needs to be discussed in this question. The basics of what is diabetes insipidus and what is CR and what is psychogenic polydipsia. But when I gave the exam long back in 2016, then I used to be very much confused between these things. The reason being, I never went in details and studied. I only studied the MCQs. After I cleared my MRCP part 1 and during my critical care medicine course, I went in details. Then I understood the pathophysiology. Anyway, so quick look at the chat box to see whether anybody has answered. Yeah, I think everybody is exam going here, but because everybody is answering correctly only. Yeah, somebody has also given the drug name also. C is because of lithium. Absolutely, lithium related nephrogenic DI. Hallmark question of MRCP, part 1 and part 2. So by the clue is bipolar patient. You see these are marked because the from the source I got, that person marked the important points, and I don't know whether it's easier or whether it's more difficult, because when you are revising it will be easier, but here they have already marked the important points. So here the things are bipolar patient, and immediately you will know that bipolar patient means there is some thing with lithium or some other antipsychotic drugs. Complaining of thirst for 6 weeks. For an experienced candidate, this line is enough that it is a lithium into diabetes insipidus. And of course, the sodium is just coming up 146 and urine osmolality is low. So it is nephrogenic diabetes insipidus. Lithium is a known cause of nephrogenic diabetes insipidus. And what is cranial diabetes insipidus? These findings will be similar. Obviously, this history will not be there. But in cranial diabetes insipidus, the ADH hormone level is the ADH hormone level is the problem is there. That is a central cause. And nephrogenic means there is a drug-induced cause, like here. Psychogenic polydipsia would have been a close DD, but in psychogenic polydipsia, what happens is the sodium level does not increase. Psychogenic polydipsia, sodium level will not increase this much. And and in CR, obviously sodium is low. CR is a condition of hyponatremia. Diabetes insipidus is a condition of hypernatremia. Always remember that, and that will immediately differentiate between CR and diabetes insipidus. Then rule out whether there is a central cause or there is a drug-related cause. Central cause, cranial diabetes insipidus. Drug-related cause, nephrogenic diabetes insipidus. Cranial diabetes insipidus usually occurs after brain surgery, brain tumor, brain trauma, road traffic accident, traumatic brain injury, or after a acute hemorrhage, acute infarct, like those things. SDH, EDH, interventricular hemorrhage, anything. Or cranial diabetes obviously can be congenital also, but that hardly ever comes in the exam. Cranial diabetes insipidus typical stem is an elderly man after road traffic accident, elderly man after a fall, that is after an SDH, elderly man after an interventricular hemorrhage, after a brain tumor operation, those things. CR question is totally different. We won't discuss that here, but CR is hyponatremia. CR is hypo. Okay. Next question, just go through it. So, what is the cause here and what is the treatment? Why do we need a treatment here? And does this condition always need treatment? Because all these questions have come in MRCP at some point or the other. Okay, I think I shall just go the stem. I don't think everybody is ready. Okay. Please write in the chat box and then we shall discuss. C, 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 E, C. What is option E, doctor? Option E is 7-day course of nitrofurantoin. C is a repeat sample. Okay. Anybody else? Okay, so only Dr. Ashish Philip has recorded E. Everybody else wants to send a repeat sample. Dr. Arijit also wants to send a repeat sample. That's fine. But Dr. Ashish is right. He is the only person who told option E, and option E is the correct choice here. 7-day post nitrofurantoin. Okay, I'm happy.
Sir,
I chose this question because I knew that you will not know the condition and anything. And yeah, please.
sir, it's a routine 12-week appointment, no, sir. First appointment with the midstream EU bacteria. Is it not we need a culture, sir, or a repeat sample so that to start an antibiotic? If it has been more than 12 weeks or is a second visit, we can directly start an antibiotic. But first routine visit at 12 weeks.
Yeah, but
Sir.
okay. So we thought, okay, we shall just discuss. So a pregnant woman who is 12 weeks, the 26-year-old pregnant woman, yeah, routine 12 weeks appointment. She has been well so far, no past medical history of note. The midstream urine reveals bacteriuria, although she has no symptoms of UTI. So the diagnosis is asymptomatic bacteriuria, right? Asymptomatic bacteriuria does not need any treatment, firstly. For any patient groups except 2, asymptomatic bacteriuria does not need any treatment. The exceptions are firstly pregnancy, and secondly, if the patient is going for any invasive urological procedure. So here the patient is pregnant. The patient, yes, has come for a routine 12 weeks appointment, and she is pregnant, and there is no past medical history. She is doing well. So why do we need to treat here? Because the sample they have told you midstream urine, so it is a good sample. So we can't tell that you have to repeat the sample, because like what will you do with the repeat sample? The midstream urine is the classical, documented, approved sample for bacteremia, right? Sorry, bacteriuria. So you don't need to repeat the sample. And what is option D? No action is necessary. Noha, they have given the option of coming back after 1 week or 2 weeks. Am I clear?
Sir, whether NFT is safe in 12 weeks of pregnancy?
Which one?
Whether nitrofurantoin is...
Nitrofurantoin is absolutely safe in pregnancy.
It's a drug of choice in pregnancy.
Yeah. So there is no issue of drug safety. 7-day course of nitrofurantoin is absolutely fine. So asymptomatic bacteriuria can reduce the fetal growth. It can cause preterm birth, and it can cause abortions. So asymptomatic bacteriuria in an early week pregnancy has to be treated. It and the drug of choice is 7-day course of nitrofurantoin. If they have given the option like come back after 1 week and see, drink more water and come back and see, then we would have, that would have been a confusion. But here they have not given that option. They have told to repeat the sample. If they are told that anything other than the MSU, that they have just collected a routine sample and something like that, then maybe yes, repeat sample. But here they have clearly told midstream urine sample, and which is the best possible sample we have taken. So there is no question repeat sample. It's a very tricky question. When I saw the question, I was not sure what they were expecting. Then obviously I had the luxury of seeing the answer. So yeah, the answer is 7-day course of nitrofurantoin. It's a good question actually. This sort of question does come in the MRCP. Yeah, Dr. Amino, I know that some repeat sample.
But you get 2 different answers, sir. I think the past test itself, twice it is repeated, once in infectious disease and another in, I think, nephrology. And both have different answers, sir. So what do you think?
Okay. Then I don't know, but yeah, I think the explanation that I've given is...
Yeah, you had because that's the explanation was very nice. So we go with that. Yes, sir. Thank you.
A 30-year-old woman presents with renal colic, dipstick urine shows blood and protein. She is diagnosed with renal calculi. what would be the absolute contraindication to lithotripsy in her case? Straightforward question. Just 30 seconds, and I think everybody knows the answer here. Okay. I think cardiac pacemaker obviously is not an absolute contraindication. Poorly controlled hypertension is never a contraindication to any operation. Stones and partial proximal fractures are also contraindications. It is an uncorrected coagulation disorder, not only for lithotripsy, but in any surgical procedure, it is an absolute contraindication. Just like local sepsis and uncontrolled, these things are absolute contraindications. Yeah. Option D. What is option D? Uncorrected coagulation disorder. Yeah, I think no need to waste any time here. Let's move on to the next question. Evaluation. Okay, just go through it.
স্টল করা হয়েছে তো এখানে আমরা নিচে স্ট্যাম্প করে তাহলে রিপোর্ট যদি থাকিয়ে দিতে পারি নিচে একটা
Again, I'll put, sir. I'll put really.
বলছি কিন্তু আমরা
I'll.
Sir, can you show the question once more?
Sure.
এটা আমাদের দেখেও কিন্তু কি লিখলো হ্যাঁ ঠিক আছে ছবি তুলে রেখে দেবো কপি দিয়ে দেবো
I think everybody has seen the question. So these are the options. Yeah, so this is the Alport syndrome, mild bilateral sensorineural hearing loss, they have told. His brother died of progressive kidney disease, they have told. So they have given both the possible explanations, and there is also some conical protrusion of both the lenses on slit lamp. So I've included this question because these 3-4 points are the ones which comes in Alports, and Alports for some reason they really like it. So there is a hearing loss, there is a family history, and patient appears pale. Yeah, hemoglobin is associated with Alports, I think. And the slit lamp examination finding is important, which is the conical protrusion of both lenses. And of course, the question itself, there is a problem in the type 4 collagen. It's a COL5A4 gene, right? So these are the 3-4 questions that have come. I have not included all the 3-4 questions, but this question covered the 2-3 topics. Let's go to the question once.
Is it hepatorenal, sir? What are you talking about?
I have shown you the options. Has everybody seen the options? Let's go to the question once. So creatinine is high, albumin is low, ALT and alkaline phosphatase are a bit high. Bilirubin is of course high. So bilirubin high, liver enzymes are high, albumin is low, creatinine is high. Potassium is of course on the higher side because of the CKD part. So patient is alcoholism patient, NSAID cirrhosis, now passing less urine, malaise, and there is ascites and pitting edema. So what is the cause?
Hepatorenal, sir. Yes. Hepatorenal syndrome.
Dilatation. Yeah. Hepatorenal syndrome is the cause. And what is the cause of hepatorenal syndrome?
Splanchnic vasodilatation and renal vasoconstriction.
Yeah. So here it is renal vasoconstriction. Yes, somebody has told vasodilatation, which is right, but that is a splanchnic vasodilatation that occurs. Renal part is vasoconstriction. That is why the kidneys are involved. So renal is vasoconstriction, splanchnic vasodilatation occurs. Decreased cardiac output, partially yes, decreased cardiac output does occur, but that is not the exact pathophysiology, right? Because of splanchnic vasodilatation, the blood is deposited there, so there is less blood returning to the heart, so there is decreased cardiac output also. That is a cardiorenal or cardioliver crosstalk. Here we don't have to focus on that. So this is a question on hepatorenal syndrome. What is hepatorenal syndrome? It occurs in a long-standing long-standing cirrhosis, and the patient usually passes less urine. There is development of acute kidney injury. The acute kidney injury ke liye, there are all the features of acute kidney injury will be present. Patient will pass less urine. There will be problems with potassium. There will be problems with creatinine and everything. And the underlying causes, there is splanchnic vasodilatation with renal vasoconstriction. There are two types, type 1, type 2, and they have changed the definitions and those things now, but you don't need to know that. A 50-year-old man presents with, I hope this part was clear, right? Hepatorenal syndrome does come. It is a more portion of the, the GI of the hepatology side, but yeah. A 50-year-old man with sickle cell disease feels generally unwell, lethargic. Which of the, okay, nothing to think here, just you have to know the answer to answer this one. Okay, so what is the answer here? Option A, Dr. Deepostri has told option A, chronic kidney disease. I mean, obviously the answer will be chronic kidney disease because we are doing the nephrology part. But sickle cell disease by itself, it's very important. Sickle cell disease, I wanted to discuss sickle cell a bit, that's why I included it here. So sickle cell disease.
Renal infarct, sir. Sickle cell crisis and renal infarcts are common, sir. Does it go CKD, sir?
Current renal infarct ultimately leading to chronic kidney disease, yeah.
Okay.
The underlying cause is that there is recurrent renal infarct. What happens is that the RBCs, they are deformed. So those deformed RBCs, they cannot now pass through the renal vasculature properly, and they get deposited there. So there is some obstruction-like thing. There is a clot or not a clot, but the RBC themselves don't allow the actual blood to pass through. So that is why there is infarct, and this infarct occurs throughout the life, in a young age till the middle age, but till that time. Repeated renal infarct resulting in repeatedly there is a chance of severe pain, abdomen, and acute abdomen-like features can present. Sickle cell crisis is a differential diagnosis of acute abdomen also. It's a rare, obviously, in like I am from India, so so in our part, Southeast Asian part, it is not that common, but in the Mediterranean part in the UK, it is much more common. So that results in CKD ultimately. Okay. Which of the following conditions most commonly associate large kidneys despite advanced kidney disease? So you know that advanced kidney disease almost always results in shrunken kidney. In our day-to-day ICU practice, all that. In my ICU practice also, we routinely see the size of the kidney, and then we measure it. And if it is smaller, then we suspect that the patient probably has a CKD. But there are some conditions in which the kidneys are also large despite the advanced kidney disease. The answer, I think, is pretty obvious here. I have not included for the answer. I just want to discuss that there is some conditions which there is large kidneys. So one is obviously amyloidosis. The other one is our polycystic kidney disease. The third is multiple, not polycystic, but other cystic disease of the kidneys. The fourth one is hydronephrosis, chronic hydronephrosis, where the actual size of the kidney is not important, but the total size is increased. So these are some of the conditions where the actual kidney size is increased even in CKD. So the option here is amyloidosis. I did not wait for you guys to answer because I think everybody knows amyloidosis has a large kidney.
Sir, in diabetes
We'll have
also,
diabetes also. Diabetes, HIV.
Yeah. Diabetes also. Right. Absolutely.
HIV, sir. I think HIV. We'll have large kidneys.
Totally.
HIV is a human immunocompromised. HIV. AIDS.
HIV you're telling. Yeah. HIV can also.
HIV, yeah.
Yeah. Okay. So post-renal transplant patient now has a problem with creatinine and high potassium. So what is the drug involved? We discussed a similar question on our first day. There the drug was different. Here they are given the other drug. These are the only two drugs which have come in the related to this topic. That drug was cyclosporine. Yeah, here the answer is tacrolimus.
Yeah.
Cyclosporine and tacrolimus are the two drugs which they usually ask in the question. There are lots of other drugs in post-renal transplant which can create, but in MRCP, the cyclosporine and tacrolimus are the most common. Go through this question. We are halfway through today's class. Let's have a look at the options. So what they have told here, they told us 75-year-old man who has got recurrent symptoms of fever and infection 4th time. He has right lower lobe pneumonia. The others were for UTI. Okay. So the 4th time, although, but some were for pneumonia, others were for UTI. So not every one of them was for UTI. There's a history of hypertension for which he takes 2 medicines. He suffered an inferior myocardial infarct 3 years ago, since when he had been taking simvastatin. On examination, blood pressure is 134 by this much. He is pyrexial and has a pulse of 90 per minute. His cardiovascular and respiratory examination is normal. PR reveals a smoothly enlarged prostate. He is passing in urine, blood, and proteins. Creat is rising. Potassium is okay. Sodium, those other things are more or less okay. Hemoglobin just a bit less. So what is the investigation to be done? And of course, if you want to know the cause of the investigation, then what is the cause of the recurrent UTI? Chat box. So everybody has told option. Different people told different options. C, B, D. I think D option is for this question. C, B, D. Okay, let's discuss. So C is intravenous urogram. Why do you want to do an intravenous urogram? First of all, intravenous urogram is never done as the first investigation of choice. Okay. Intravenous urogram is not the answer, doctor. Whoever has told it is not the answer. Cystoscopy. We would usually do a cystoscopy if you suspect there is a bladder mass, there is a malignancy, this sort of things. Let's see what they have told. They have told that cardiovascular respiratory things are normal and hemoglobin is low. Okay, because hemoglobin is low, so you think that an elderly man with recurrent pneumonia probably has got a mass, and that's why you want to do the cystoscopy. Which actually not a bad process of thinking, but yeah, I'm sorry, that is not the answer here because there are other, two suggestions something else. Elderly man, number of times he has got an UTI, 2 times UTI, this time again an UTI. He is hypertension, those things are okay. Now there is a suprapubic tenderness, and there is a smoothly enlarged prostate. Smoothly enlarged prostate. So it's not a roughly enlarged prostate. A smoothly enlarged prostate means it is a normal prostatomegaly. That is, it is not a malignancy. That is why it is. You don't need to do cystoscopy here. Okay. Cystoscopy हो गया, intravenous urogram हो गया, CT pelvis. CT pelvis obviously can be done, and a PSA measurement and a post-void residual bladder volume measurement. So look at the question. The question is, we want to do the additional investigation to elucidate the cause of the recurrent UTI. Okay. They have already told that the prostate is enlarged. So the PSA will obviously be enlarged. The option E, the process-specific antigen. So what extra value will you get by learning from the PSA measurement? Nothing. Now coming to option D, post-void residual bladder fluid measurement. What is happening here that the patient has got a prostate enlarged, which is the, in small 70-year-old man, smoothly enlarged prostate is okay. There is suprapubic tenderness because of the UTI, and because the enlarged prostate is such a large size that now it has resulted in incomplete micturition. So there is some collection of urine in the bladder, and that is why there is recurrent UTI. Okay, this is the whole scenario that they are trying to portray here. That is why option D is the right answer. It is post-void residual bladder volume measurement. If you see WBC count is 13,000, so it is just more than 11, so not too much raised. CT pelvis, some other source of infection, some abscess, the patient will be extremely sick with WBC count much more than that. That is why CT pelvis is not warranted. Here everything is pointing towards a prostate related cause. So option D is the correct answer here. It's a very good question. It's a very clinical based question and very logical question. I hope everybody understood the explanation and everything. Okay. So 78-year-old, that is elderly person, textile worker, painless hematuria. He is taking some anti-inflammatory drugs. No evidence of renal stones. Routine blood is mild anemia with a hemoglobin of 105, ferritin just below the normal range. So what is the cause here? Is it analgesic nephropathy? He does take some anti-inflammatories. Bladder cancer, textile worker, elderly person, painless hematuria, some anemia is there.
Most common is bladder cancer.
Yeah. Chronic UTI, they have not given anything that there is chronic UTI. There is no renal stones. So interstitial cystitis, interstitial nephritis, there are no features here. So I think anybody who has gone through nephro once of MRCP knows that a retired textile worker, painless hematuria is bladder cancer. And another drug is cyclophosphamide, which is also very commonly given in MRCP. History of cyclophosphamide, or a patient who has some rheumatological disease, some immunologic disease, for which cyclophosphamide is used. There also painless hematuria is bladder cancer. It's the cause of bladder cancer, transitional cell carcinoma, clear cell carcinoma, transitional cell carcinoma. Okay. So basically a repeat question from our last two discussion classes. We already discussed, I think, 10 to 15 of these questions. Yes. So gastroenteritis for a few days, not weeks, mind you. I have discussed in details what's the use for these weeks and days. Past medical history of note includes furosemide ramipril for systolic heart failure. Full blood count and film reveals evidence of red cell hemolysis and thrombocytopenia. Serum creatinine is high. So, doctor, which is the answer here? Gastroenteritis, thrombocytopenia, serum creatinine is high.
Hemolytic uremic syndrome.
Yeah, I think everybody agrees here. If you guys did not agree, then I would have been like, what did I teach in the last class? Anyway, I think it's a pretty straightforward question. Hemolytic uremic syndrome is once again I think every option given here is an MRCP favorite. Acute dehydration, furosemide toxicities, GPA, AQS, renal artery stenosis. This question just come again and again and again in MRCP. Okay, so painless neck lymphadenopathy to a young female, night sweats, fever. Immediately we are thinking of some, what are you thinking? Just tell me.
Hodgkin's and
yeah, pain after drinking alcohol.
disease.
Yeah, Hodgkin's, non-Hodgkin's, those type of things you are thinking immediately after painless neck lymphadenopathy, young female, night sweats, fever, and malaise. Right. And there is peripheral edema. There is decreased in albumin. There is 24 urine collection is showing a more protein restriction. Renal biopsy, nothing significant. So it is a minimal genetic disease. And I mean, even if you don't diagnose the Hodgkin's part, there is no significant abnormality with a more than 3 grams of 24 hours of protein excretion, so a nephrotic and proteinuria. So the answer is minimal genetic disease.
Sir, can you go slow?
Yeah. Did you get through this question? Just tell me when you want me to go slow. There is no issue.
Okay, sir.
Yeah. Let's go through this question. We'll give you a minute. Just write in the chat box the answers.
Sir, please show the options.
So what they have told here, they have told that the 18-year-old man, young man, presented dark discoloration of urine, which we know that it is blood. There is a history of UTI with severe pharyngitis 2 weeks ago. He was previously fit and well. On examination, he has a puffy face with periorbital edema. So the upper urinary tract, the upper respiratory infection occurred around 2 weeks back. So, doctor, what is the diagnosis?
Post-streptococcal.
Okay. Everybody agrees with this because the 2 weeks is the time period given. So it is the time period for PSGN, post-streptococcal pulmonary. Okay. So a young man, 2 weeks history of severe pharyngitis, now presents with periorbital edema, high end blood pressure with blood in urine. So like which of the following is likely to occur? Let's see what you have written in the chat box. Yeah, everybody agrees that it is option E. It's proteinuria. So a simple question, but it came I think in 2 years back. So it is actually a question of MRCP. So some questions are simple enough.
Sir, one doubt, sir. In
Yes.
IgA nephropathy also similar condition occurs, like after upper respiratory infection, patient developing nephritis.
But that's only 2 to 3 days post.
Yeah, doctor. It's good that you asked, because it's very important to clear. These 2 weeks, that time period is important. The IgA nephropathy, so suppose the patient has got a upper respiratory tract infection, and after that the patient develops a kidney injury resulting in proteinuria, hematuria, rising creatinine, edema, anything. So this gap between this respiratory tract infection and the kidney problem, that you need to find out. That for a PSGN, post-pneumonephritis, will be at least 2 weeks, at least 12 days, 14 days, something like that. For exam purpose, at least in IgA nephropathy, it will be few days, 2-3 days, 4 days, less than 1 week. So less than 1 week, more than 10 days. That is the cutoff. Less than 7 days, it is IgA nephropathy. More than 10 days, it is PSGN. In exam, I can guarantee you they will give a clear-cut distinction. 2 to 3 days ke jyada, more than 2 to 3 days, they will not give. Less than 2 weeks, more than 10 days, that that gray period they will not give for PSGN. So for PSGN, they will definitely give you 12 to 14 days. For IgA nephropathy, they will give you 3 to 4 days at max, or 1 to 2 days also they can give. So there will be no confusion regarding that. You just have to give importance to that. You just have to find out why it is written. That's it. That's the only way to differentiate in an MRCP exam between IgA nephropathy and PSGN. The time period. There is no other way to differentiate. Because the differentiation needs a renal biopsy or the IgA level, those things. That will not expected of you in an MRCP exam anyway. So that is the way how to diagnose. So I think everybody, even if you don't get diagnosis here, you can answer it is proteinuria. But in any of these questions, even outside this class, try to find out what is the diagnosis. Try to diagnose on your own, then go for the answer. That will help you in some other questions also. Anyway, moving on. Just go through that question and we shall discuss once again. I don't think we have discussed renal tubular acidosis in last 2 classes. We shall discuss it for at least the salient features today. I mean, right now after this question. I will give you a couple of minutes for this question. Okay. So just write in the chat box the answer, or like if you don't know renal tubular acidosis, no need to guess or anything. So
It's a question. So one more. So one question for Melissa, sir.
Yeah, ask. I did not get you. Okay, you want to see the question? Okay.
Yes, sir.
Yeah, take some time. So DAD. Symmetrical answers. So somebody has told type 4 renal tubular acidosis. Another has told acute tubular interstitial nephritis. doctor who has told acute tubular interstitial nephritis, if they wanted the acute tubular, yes, I know that there is a 15-year-old history of rheumatoid arthritis, regular and diclofenac, so ATN is a possibility. But they are told that there is a decreased pulmonary testosterone and mild CKD. So acute tubular interstitial nephritis is not present with a CKD-like feature, right? It is an acute cause. Okay. So why the CKD? That is not, not explained by the ATN part. Am I clear? If the patient cannot have both acute kidney disease and chronic kidney disease simultaneously, right? So it's not ATN. It's one of the renal tubular acidosis. Obviously, here they have told that there is a hyperkalemia.
Hyperkalemia, so it shows D.
Yeah, so I mean, there is
decreased
no
plasma
confirmation
renin and
there.
aldosterone also. So
Yeah,
type 4
even
is
they have not mentioned that hyperkalemia only occurs in only type 4. Type 1 and type 2 both have hypokalemia. So hyperkalemia means there is a type 4 renal tubular acidosis. I mean, among the renal tubular acidosis, it is only hyperkalemia only occurs in type 4, right?
Yes, sir.
Everybody knew that, right? Yeah.
Yes, sir.
So what about type 1 and type 2? How to differentiate? Because type 1 and type 2 both will have
Calcinosis, hypokalemia.
Yeah. So which one?
Type 1.
Yeah. So type 1 and type 2 both have firstly both have hypokalemia. Secondly, both are causes of non-anionic metabolic acidosis or metabolic acidosis. I don't know whether you know non-anionic or anionic those things, but non-anionic metabolic acidosis, type 1 and type 2 both, and hypokalemia. So how to differentiate? Type 1, what is type 1? Type 1 is distal type of renal tubular acidosis, and type 2 is the proximal variant of renal tubular acidosis. So type 1.
In type 2.
Yeah. So to differentiate, there is another, we have included another question later on. In type 1 and type 2, to differentiate, you need the urine pH and the calcium levels. Okay. So in type 1, the body, despite the high acidosis levels in the blood, the urinary pH will be more in the alkaline range. It will be more than 5.5. Usually it is quite high, more than 7, 7.5, something like that. At least more than 5.5 will be there. Why? Because the problem here is the distal part of the kidney where the urinary acidification occurs. So urinary acidification cannot occur here because the distal part of the kidney, distal part of the renal tubule is not working. So there is renal tubular acidosis type 1. The urinary pH will be more on the alkaline side, at least more than 5.5. And type 2, urinary pH will be low, as expected in a case of acidosis. Yeah. So that is the way to differentiate. We have another question. We shall discuss it there again.
Sir, calcium, sir, nephrocalcinosis is common in type 1, not in type 2.
Yes, nephrocalcinosis is common in type 1, not in type 2.
And type 2, we have more of aminoaciduria and all, Fanconi-Stich syndrome, where
in type 2, remember that everything is excreted. Calcium, phosphate, those amino acids, sugar, everything. So type 2, yeah, Fanconi is type 2 and type 1 is nephrocalcinosis, and urinary pH is more than 5.5. And
sir, in type 2, everything is decreased.
Type 2, there is excretion of everything. Yes. The question will not come regarding the decrease in the blood level. The question will come that there is proteinuria, there is glucoseuria, there is calciuria, there is phosphaturia, there is features of Fanconi syndrome, like that. Okay. Am I clear? Remember what will come in the exam. Obviously, if these things are passing out in the urine, that is decreasing in the serum also. That is obvious. But if some protein goes out in the urine, that may not be reflected in the serum, right? If some glucose goes out in the urine, it will not be reflected in the serum. So the patient may have normal glucose level with glucoseuria. So don't remember it as hypoglycemia. The patient may not have hypoglycemia. The patient will have glucoseuria. You are getting what I'm trying to tell, right? Don't remember it by the serum levels. Remember it by the urine levels. Urine level में सब कुछ is increased. There is increased excretion of protein, glucose, तुम्हारा albumin, calcium, phosphate, everything in type 2. And type 2, the urine pH is less than 5.5. So the kidney is able to acidify the urine. In type 1, the urine pH is more than 5.5. and there is more chance of nephrocalcinosis because calcium excretion decreased. So there is deposition of calcium in the kidney. That is why more chance of renal stones in type 1.
And another one, most common cause for type 4 is diabetes.
Type 4, yeah, diabetes.
Diabetes type.
And type 4, they will always give you this hyperkalemia because type 1, type 2, both are hypokalemia. Type 4, they also give you the decreased plasma aldosterone, both are decreased. Other than diabetes, other causes are if the patient is on ACE inhibitors and ARBs, that is angiotensin receptor blockers.
Yes, sir. Yes, sir.
Drug mediated. Okay, go through this question. Okay, so I think everybody going through the question. And 73-year-old peritoneal dialysis patient presented with a 2-day history of abdominal pain and cloudy dialysis effluent. She has been on dialysis for 2 years and also the history of CAD. Clinically, her abdomen is rigid and distended with absent bowel sounds. Blood pressure is 85/50 and pulse rate is 120. Culture of dialysis reveals a mixed growth of these. So which one of the following is the most likely cause? So as I was about to tell before I got disconnected was somebody has told that, not somebody, a few people have told that it's the primary peritoneal dialysis peritonitis. Why? What is the definition of primary peritoneal dialysis peritonitis? Because the question clearly mentions why it is not that answer. That last line that they mentioned. Okay. What is the chat gone? Okay, the previous chat has gone off now. Anyway, so some of the participants mentioned that it is primary peritoneal dialysis peritonitis. In a primary peritoneal dialysis peritonitis will not reveal a mixed growth of E. coli, bacteroids, and enterobacter ductors. There can be one growth of E. coli or some other organism. Okay. A 3 growth means there in a there is other things. The abdomen is rigid, distended, absent bowel sounds. Blood pressure is low. She is in shock basically. Pulse rate is high. So there is the most common complication of this peritoneal dialysis. There is some gut injury, bowel injury resulting in diverticular perforation or diverticulitis perforation. That is why there is a misgrowth of E. coli, bacteroides, and enterobacter. So that is the clue why it is not primary peritoneal dialysis peritonitis. I hope it, and obviously the BD are not the answers here. Are you clear why it is diverticular perforation or gut perforation and not a primary peritoneal peritonitis? That is the very reason why I included this question here. A primary peritoneal peritonitis will never have 3 or not, let's say 3, not only have 2 also. It will not reveal a mixed growth, never a mixed growth. Mixed growth with features of shock and rigid abdomen means there is a gut perforation. There is no other explanation for that.
The most common organism is staph epidermidis. Usually we have.
Gut perforation?
No. In peritonitis. PD associated peritonitis.
Yeah, because
secondary infection, most common from skin infection. Maybe.
Yeah, most common skin infection, gram-positive organism, staph. Yes. Okay. Just go through the question. We have already discussed this question in the last class details. I shall give you a couple of minutes. It's long stem.
Is it vaginal, sir?
Yes.
Can't see the options.
Yeah, I have not shared the option. Just everybody went through this part of the question. These are the options. I think everybody got the diagnosis that it is what is called Wagner's granulomatous. There is collapse of the nasal bridge, recurrent sinusitis, recurrent upper respiratory infections, and there is involvement of kidney, involvement of chest, bilateral diffuse hazy pulmonary opacity, so pulmonary also Wagner's granulomatous. And yeah, it's Everybody is still option A. It is option A, obviously. The antecedent history. Okay. So here it's a long stem. So the patient is taking sulfasalazine for rheumatoid arthritis. She has developed painless hematuria, and there is also hypertension for which she takes ramipril. So she takes 2 drugs, ramipril and sulfasalazine. Now her blood pressure is more or less okay, a bit on the higher side. Obvious sense of rheumatoid arthritis affecting her hands, wrists, and elbows, and is a rash over the sun-exposed skin. So what is the diagnosis here? Okay, the following is the most useful investigation to confirm the likely diagnosis. So go through the question, and I showed you the stems, and I shall share you the stem after 30 seconds. Go through the question once. I share you the options after that.
Sir, please show the options.
Questions and options.
One second. Yeah. This is the question. Has everybody got the question? Then I shall show the options. Everybody got a diagnosis here, right? There's a rash of sun-exposed skin, the history of sulfasalazine exposure, and there is signs of rheumatoid features, right? Patient also takes ramipril. Painless hematuria is there. A rash of sun-exposed skin, there is only one diagnosis in MRCP, right? It's either, yeah, let's see what options you have given. I think everybody is going for the, okay, renal,
Options.
I showed the options. Yeah, these are the options.
Sir, can you explain it?
Yeah, I shall explain. I shall obviously explain. I am just waiting for some people to write the correct answer. Okay, I think somebody has told us renal biopsy. I think both of them have told renal biopsy. So, what is the diagnosis? Can somebody tell me? Like, what is this elderly lady suffering from? Not too elderly. 64-year-old is not too elderly. Somebody told HS. I mean, the spelling I think is wrong. But did you want to tell about inoxaglin HS purpura? Dr. Amino, Dr. Farah. Dr. Nagaraj has told option E. What is option E? Urine cytology. Okay. Why do you think we have to do urine cytology here, doctor? Urine cytology is for malignancy only, right?
And rash with a drug-induced and painless hematuria. I thought it's malignancy. Like, I'm not sure. So I chose cytologist.
Okay.
I thought this diagnosis is Henoch-Sinon Brubura.
What is the diagnosis, doctor? HS purpura.
Sir, it's an
Inoxaglin purpura, sir. What she's Inoxaglin purpura. That is what I think she has written.
HS purpura, right? But HS purpura, I mean, what is the clue to HS purpura here, doctor?
Because of skin rash, I think.
Sir, it's a case of SLE. So in renal biopsy, likely there will be a diffuse proliferative glomerulonephritis picture, what we expect to get.
Yes. Probably renal biopsy is the correct answer.
Yes,
SLE linked.
That is the correct answer. But I mean, doctor, don't overthink things. These are all previous year's questions, and previous year's questions are straightforward. Okay. Painless hematuria. Yes, I know painless hematuria is a common, pointer towards malignancy, and that's why somebody has gone for this cytology. But rash over sun-exposed skin, sulfasalazine, the whole thing should come into effect, right? There is no note of the hemoglobin is 115, it is not low. ESR is 13. There is no mention of loss of weight, right? So, like, only painless hematuria, you can't directly go for malignancy unless there is some, family history given or some other pointers for malignancy are given. Especially when other more specific pointers are given, rash over sun-exposed skin, history, signs of rheumatoid, sulfasalazine. These are all pointing towards only one diagnosis, which is SLE. I mean, rash over sun-exposed skin, is there any other diagnosis in MRCP? Tell me. I think you guys are getting good answers throughout.
Photosensitive rashes, sir. Rash over the sun.
Porphyria, sir.
Porphyrias.
Yes, porphyria. Yes. If you are going to porphyria, then it's fine. But porphyria, it's not a porphyria, right? We have not mentioned anything about porphyria.
Sir, okay. So to me now it thinks more like instead of a straightforward SLE, it looks more like a drug-induced lupus, sir.
Yes, it is drug-induced lupus.
Not a straightforward SLE.
Sulfasalazine.
Sir, why not?
Lupus
Hello, sir.
nephritis. Hello.
Yeah, tell me, I can hear you.
Sir, why not amyloidosis, sir?
Drug-induced.
Amyloidosis. Doctor, I mean, why are you looking amyloidosis here?
Sir, long-standing rheumatoid arthritis
Okay.
on
What else?
the hematuria part and renal
So suppose
amyloidosis, basically.
then you go for rectal biopsy here.
Yeah, that's
But
it.
how does
Nice.
sulfasalazine fit in?
Okay, sir. Yeah.
Excuse me.
Sir, I think we are carried over by your marking, sir, yellow marking. If it would have been a straightforward question,
If it is going towards the lupus,
I think we are biased by that.
I think somebody is telling something. Yeah, doctor, please.
If it is going towards lupus, taking sulfasalazine rash over the sun-exposed area, it can be lupus nephritis because creatine is increased. There is protein and blood in the urine.
Doctor, it is lupus nephritis. That is why the answer is renal biopsy. Actually, just explain it one second. So, 64-year-old woman who is taking long-term sulfasalazine therapy for her rheumatoid arthritis is referred to the clinics by her GP as she has developed painless maturia. Other past history of note is hypertension for which she takes ramipril. On examination, blood pressure is okay. There are obvious signs of rheumatoid affecting her hands, wrists, and elbows, and the rash over sun-exposed skin. So, what are the clues here? The patient is on sulfasalazine. There is rash over sun-exposed skin. Patient has history of rheumatoid arthritis, and RA and SLE often coexist together, and SLE often comes into view later. So that is clinical part. But if for MRCP candidates, a history of sulfasalazine take rheumatoid-like features with a rash over sun-exposed skin, there is only one diagnosis, which is systemic lupus erythematosus (SLE), and that is why creatinine is high, urine, there is blood and protein. And once you get the diagnosis, the answer is obviously renal biopsy. Then there is nothing else. Nobody else will think anything.
Renal biopsy, right?
So you have to make the diagnosis here. The diagnosis: why it is rash dragged into lupus? Because of sulfasalazine. Why is it lupus? Because of the rash of sun-exposed skin and a history of rheumatoid arthritis or rheumatoid-like features. Okay. Go through rheumatology questions once. Once you move through 50-70 questions of rheumatology, you will get a hang of it. It's a very common question. It's not difficult. There will be at least 1 to 2 questions of SLE, RA, or miscarriage disease in your actual exam also. Okay, it's good that I didn't want to include this question because I thought that this is mostly of the immunology or rheumatology question. But it's good that I include this.
Sir, one more doubt, sir. You see, if a patient on underlying for treatment for rheumatoid arthritis develops SLE with renal involvement, how would we be treated like for lupus nephritis and rheumatoid arthritis for skin and other things, sir? Hello?
The treatment will be on a terms of mixed connective tissue disease. And the drug of choice is steroids. Okay. You have to give some pulse therapy of steroids and then a continuous therapy of steroids. And then because obviously here sulfasalazine needs to be stopped, right? And so some other drug needs to be given. Here they have given for the theoretical part for your MRCP exam.
Yeah, I can understand.
But it treats rheumatoid arthritis with sulfasalazine now. Okay. The drug of choice is steroid. Yeah, the drug of choice is steroid. Somebody uses methotrexate, much less. And if finance is not an issue, then other drugs, rituximab, those drugs are also used for IL-6. So that is another thing. No need to go into that. But here the patient is treated like a mixed connective tissue disease, MCTD. Diagnosis needs to be done not only by rectal biopsy but by other biomarkers and antibodies also. And the RNTCP is the drug of investigation that needs to be done in this case. That is not something very high-fi. That comes in MRCP part 2 only. And once you go for PACES, you'll see that PACES also has got this sort of questions and answers. Anyway. A 45-year-old woman presents with increased frequency of micturition, dysuria, suprapubic pain for 5 days after completing an antibacterial treatment for E. coli. Now she is using a barrier contraceptive. She has got a recurrent UTI history. Now there is E. coli in her urine microscopy. Okay, so just go through this one. So I will give you a minute. Okay, doctor. So what is the answer here? There's nothing much to think actually here. It's a, it's a sort of question which you chlamydia urethritis. Why? There is no chlamydia here, right? What do you think is chlamydia? Somebody is told use a spermicidal jelly. Okay. Doctor, just because it is a third class doesn't mean that the questions are, something else. These are still the similar level of question that I was doing in the other two classes. Don't go for the atypical option. Don't go for the atypical things.
Okay, okay. So, micturition, dysuria, suprapubic.
All of these questions are past year's questions only. I have not made the questions up. These are not, some out of the box questions.
Is it interstitial cystitis, sir?
Let somebody else just give the others a couple of minutes to think. Because I think everybody is thinking out of the box suddenly. Okay, B, E, C, A. Okay, so most of the most of the people are going with option C. Interstitial cystitis. Nobody went for option D, right? Okay. Yes, Dr. Arijit, renal stones. So, okay. So this is the question which we need to rule out the options one by one. Atrophic vaginitis. 45-year-old woman. She is using a barrier contraceptive, and there is increased frequency of other things. So as 45-year-old, you won't expect an atrophic vaginitis. So that rules it out. Chlamydial urethritis is uncommon. They have not mentioned anything pointing towards chlamydia. So that is not the answer. Interstitial cystitis, yes, it can be interstitial cystitis. Option E is not the answer, doctor. Option E, I don't know why they given. I have no idea what it causes. Interstitial cystitis and renal stones are the two remaining. Renal stones, doctor, is one of the causes of recurrent UTI because it causes post-obstructive, post-stone obstruction that results in difficulty in passing urine, that results in storage of the urine in the bladder or in the tubule or in the ureter, that results in UTI. So interstitial cystitis. Why do you think it is interstitial? Because that is, I think, is the most commonly.
There is suprapubic pain.
Okay.
Frequency of micturition and suprapubic pain.
Yeah. Okay. But why do you think it did not get treated by the, she has completed antibacterial treatment for E. coli, and urine microscopy shows E. coli, right? So she has received a full course of antibiotics for the organism which was causing the UTI. So why has it not resolved? And why there is a history of recurrent UTI? As I told you, every line is important in an MRCP question, especially in the short stems. Now I've told you, you can realize that they have told that urine microscopy shows E. coli. So it's not like that there is some other organism, some Klebsiella, Pseudomonas, and you have treated for E. coli, and it has not resolved. So there is a persistent this UTI. You have treated her for UTI, you have treated her for E. coli, and she has E. coli. then obviously UTI is not that difficult to treat. She is not immunocompromised. She is not any post instrumentation. She is not a high risk for recurrent UTI. She is a normal 45-year-old woman, sexually active 45-year-old woman who is having recurrent UTI. So why not renal stones? Is there anything here which rules for renal stones? There is no, right? So don't think about chlamydial urethritis and spermicidal jelly. Think why it is not renal stones. Renal stones is the more common answer here. Here the patient is having recurrent UTI, right? Recurrent UTI, you have to find out that must be a cause. Atrophic vaginitis, if the age was 60 plus, 65, 70 years, then atrophic vaginitis would have been a very good call. But it is not so here. So the answer is renal stones, and it is, this question has come either in this shape or in some other shape, like how to investigate USG, X-ray, MRI, something like that. The answer is USG first, then X-ray. So yeah, recurrent UTI, the most common cause is renal stones or some renal mass, something like that. Okay. So what is the child suffering from? Not a child, the 18-year-old student.
Measles.
Measles.
Yeah. And what is the renal biopsy finding of measles? Lymphocyte is type 1, type 2. Okay, I think it's a 3 to 4 years earlier question. Type 1, type 2, not that common. Just tell me whether it is focal or diffuse or meson, or the what to call it, MSGM. Sorry, MCGM. Okay. Of the option, there must be something mentioned for which it's very fast. They have not mentioned anything regarding that. Start with diffuse focal or mesenteric. Find it on the step. Measles is associated more mesenteric. So the answer is type 2 mesenteric, which is the answer here. But I think you won't get a type 2 or type 1 mesenteric now. It has gone out of the protocol to mention type 1 or type 2. Just remember, it is type 2 mesenteric for this question. Overall, measles is mesenteric pneumonia. It's a memory-based question. Nothing to think about it here. Okay. This is another question which requires some thinking. Not a usual memory-based question. Yeah. So first you have to find out what is the man suffering from. Only then you will get the answer that obviously what diagnosis is most likely to explain an answer. So acute hot and painful right knee with a history of alcohol excess in a 30-year-old man who is otherwise apyrexial. So what is the answer here? I mean, what is the cause here? Take your time.
Sir, please show the question.
Yeah. No need to hurry. Just read it 1 or 2 times.
It is monoarticular involvement of the right knee.
Right.
And then alcohol excess.
Okay.
And urine dipstick is 2+. Is it a stem about any pseudo gout or such anything? Or a gout like gout? And
Okay. Why do you think it is pseudo gout and not gout? Is it have they mentioned it?
It's gout only, sir. Gout. Gout again. I think gout gets exacerbated with alcohol, sir. Yeah, it's gout again. Gout, yeah. Gouty arthritis with probably. Is it urolithiasis? Hypercalcemia?
Okay. So has anybody else told anything? Urolithiasis, E, everybody has told D. One new message, or again option E. So D and E. So D is UTI, E is urolithiasis. UTI. They have clearly mentioned that the patient is apyrexial. Please go through the question. I specifically mentioned that the patient is apyrexial with a normal WBC count. So it is not UTI, right, doctor? You see, everybody knows it. As soon as they
yes,
8 and 12 that whoever has answered, they must also be thinking that why did they answer UTI? Because the patient is apyrexial, the blood test shows a normal WBC count, so no signs of infection. At least, no signs of systemic infection. So it is not UTI. Post-infection gain is obviously not answered. They have not mentioned anything about like that. IgN is not answered. So you're stuck with option E.
Pyelonephritis and E.
Pyelonephritis, why not? Because it's apyrexial and normal WBC.
Normal, yes, sir. So only E is answered.
So only E is remaining. So that is the way to rule out the answers and go to one answer. So suppose you are not able to do that. So what is the question? Acute hot and painful right knee, history of alcohol excess. So probably pseudogout. On examination, his apyrexial, blood pressure was normal. Urine dipstick shows +2 blood. Blood test shows the raised urea creatinine level. Pseudogout, doctor. What is the most common cause of pseudogout? Tell me.
Calcium.
Yes. And that is why the answer is
urolithiasis. Yeah.
Because the stone is forming.
Okay, fine. Yes, sir. Sir, does gout, pseudogout get exacerbated with alcohol, sir?
Yeah, pseudogout is the one who is exacerbated with alcohol. And gout gout can also get exaggerated actually. That is
yes, sir. Gout and pyripheries.
Yeah. But even if it is gout, then it can be uric acid stone also.
Uric acid stone, yeah. So I thought of uric acid stone, sir.
Yeah.
After.
History of recurrent actually it is difficult to diagnose from here whether it is a gout or pseudogout.
Okay.
Anyway, you don't need to diagnose it. You just
have
to 52-year-old woman, the history of recurrent UTI presents. You go through it. I'm also going to. Oh, it's a simple question. So what is the answer here? I think everybody has written the answer already. Yeah.
Xanthogranulomatous pyelonephritis.
Yeah. The lipid-laden macrophages with a left-sided abdominal mass. The answer is MRCP. Nothing much to discuss here. Once again, a memory-based question. Of the following disorders, which one can cause acute renal tubular damage? Straightforward question. We have discussed, I think, 3 to 4 questions on this topic in the first class. The answer is myoglobinuria, right? Everybody.
Yeah, rhabdomyolysis.
Yeah. So So we discussed about rhabdomyolysis and rhabdominuria in the first class itself. It's a very important topic. If you have any questions which I am going first, just ask me. Okay, these are all memory-based questions. Nothing much to explain in these questions. Okay, so this is a more thinking-based questions. Okay. So recurrent UTI with hypokalemia, with metabolic acidosis, with urinary pH 6.5. So what is the diagnosis? Just write it down or tell me. I won't be giving the options because options are the option will help you.
Yes, acidosis, hypokalemic, metabolic acidosis.
What is your voice is very it's distant.
Type 1 distal tubular acidosis.
Okay. Type 1 renal tubular acidosis. So we have already discussed this, but I should just give some options to other candidates if they want. So option A is CKD, type 1, type 2, type 4 RTA, and ureteric stone, right? So if somebody else wants to write something in the chat box. Okay. Dr. Moshumi, Dr. Depository, Dr. Farah, everybody written type 1. I hope Dr. Depository written type 1. Yeah. So as we already discussed, type 1 urinary pH is 6.5, so more than 5.5. There is severe metabolic acidosis, bicarb is 12, and potassium is low. So it is not type 4, and type 4 goes out. Type 1 and type 2 from the urinary pH we can find it out. They have not given calcium, so we can't use that. So that is the way. Okay, another thing, nobody told it, I missed it. The chloride is given 5. So in type 2, the chloride will be low, not high. Okay, because as I told, there is hyperchlorohydrouria. So chloride is also lost in urine. So chloride will not. So that is also differentiating from type 1 and type 2. They mentioned it here. Okay. So infective diarrhea after 1 week, 17-year-old teenager, fever, hypertension, hematuria, elevated creatinine. They have marked that she worked at a farm before. I don't know what is the clinical. They have mentioned in the explanation also that the farm thing is very important. I think because of some exposure to the farm animals or something maybe. So yeah, tell me what is the diagnosis. It will give you a minute.
Hemolytic uremic syndrome.
Yeah, doctor. So like in HUS, what is the use of this farm? I mean, why have they mentioned it? I thought that they mentioned it just like that, but I found it in the explanation that they have told that this farm thing is what is pointing towards HUS. It is HUS anyway. That so there are a lot of other things in there. I'm just asking. I don't think HUS is related to any farm animals or exposure to dairy things, right?
Yes, sir.
But
why they have mentioned the farm thing.
Probably to misguide us, sir.
Pardon?
Probably to misguide us.
Misguide, but they have told in the explanation that it is related, HUS is related to farm. I don't know honestly. Anyway, leaving that aside, why is it HUS? There are lots of other pointers like the infective diarrhea, hypertension, nephritis features. Yeah.
I think when you put a question, with this marker, no, sir, we see only the marker and that goes into our.
Yeah, actually, I took it from the past test series, and I don't know why. I mean, I downloaded it from somewhere and it was marked like this past medicine series. The past tests and on exams are okay, like as we discussed in last 2 times.
No problem, sir.
Yeah. this is a more pathophysiology based question. Use your time and take it. So, tricky question. Okay, so what is the answer?
Yeah, no,
A. Okay, let's see what the options are. B is increased plasma endothelium 3. E is pleural effusion. A is hypertension. Doctor, they have given the diagnosis nephrotic syndrome. The patient will never have hypertension. Okay,
hypertension.
so hypertension is not the cause. Go through the questions properly. I think everybody knows that nephrotic and nephritic may difference. There is no hypertension here and there is hypertension there. Don't confuse the simple things. Nephrotic syndrome, they are told hypertension will not be the answer. A is gone.
And there is
Somebody has told increased plasma antithrombin 3.
There is decreased plasma antithrombin.
Yeah, there is a nephrotic syndrome is a hypercoagulable state. There is a decrease in plasma antithrombin 3, not increased. So plasma option B is not the answer.
Sodium excretion also is less.
Still increase urinary sodium excretion to
wrong. Sir. Intravascular volume depletion also.
Sir, what's the answer, sir?
Pleural effusion.
Don't worry, I'm telling you. Pleural effusion. Nephrotic syndrome, they are told what is the most likely to accompany nephrotic syndrome. Okay. Pleural effusion, but the nephrotic syndrome is not that common, right? Nephrotic syndrome, yes. Obviously, excess fluid overload, ultimately pleural effusion is there. Nobody went for the right answer. Intravascular volume depletion. Why? Nephrotic syndrome is a fluid overload state. The fluid is not inside the blood vessels. It is in the third space of the body. That is why there is ascites. That is why there is pleural effusion in the latter stages. Intravascular volume depletion is there. It is the pathophysiologic hallmark of nephrotic syndrome. The body's volume is increased, the total blood volume, the total water volume. The volume inside the vessels, that is the intravascular volume, that is decreased. Why? Because there is low albumin. The albumin ke liye there is oncotic pressure. The oncotic pressure holds the fluid back inside the blood vessels. Because there is a hypoalbuminemia of 2.5 grams per DL or 25 grams per liter. So the fluid is no longer in the intravascular compartment, it is in the third space. It is outside the blood vessels. It is in interstitium. So there will be intravascular volume depletion. I don't think everybody understood it after my first.
Yes, sir. It's fine. Yeah.
If anybody wants, I can repeat. This you need to know not only for MRCP, for the rest of your medical career. You need to know this. That a pleural ascitic condition patient, a nephrotic syndrome patient, they always have an intravascular volume depletion because the fluid is outside the fluid outside the vessel. It is in the third space. It is in the interstitium. It is in the abdomen ascites. It is in the pleura. It is in the for the pleural effusion, not in the blood vessels. Not that is why there is hypovolemia. That is why the heart becomes weak. The heart tries to pump the low volume that is returning back to the heart. So there are so many cardiovascular problems in these patients. Am I clear?
Yes, sir. Yes, sir.
Yeah. Okay, it is once again a memory-based question. What is the greatest effect on GFR from the MDRT equation?
It is the muscle mass, sir.
Yes, it is a muscle mass. So can you tell me what is the problem with this MDRT equation or the calculation of GFR from this MDRT equation? Because you see, in the MDRT equation, what we have told is a muscle mass, right? So suppose you are telling in ICU there is a 87 years old male patient whose body weight is 37 kg and his creatinine is 1.1.
Okay, yes, sir.
And another person, 37-year-old male patient, the 70 kg body weight, has got a urinary creatinine of serum creatinine of 1.1. Is
Yes,
the
sir.
creatinine clearance same for both of them?
No.
It's right. And suppose a 120 kg person has got a creatinine clearance of 1.2, 1.3. It differs on the basis of muscle mass, and it's very important to remember that.
Yes, sir.
Remember, it's not on the body weight, it's in the muscle mass. So suppose these wrestlers, these boxers who have got all the muscles of the body very prominent, so they will have a higher creatinine. So that is the best in creatinine. So it is very important to know the best in creatinine.
Okay.
Because GFR classification is based on that only,
Based on
90%, yeah, 25% decrease in that. I think it's the last question of the day. Okay, we shall do this question first and then the previous question. So what is the most common problem among these 5 options in a case of CKD undergoing HD? I don't know why they had to mention a widow. Anyway.
The C, sir. Protein,
See,
the protein calorie malnutrition, definitely. So can you get, you won't need this for MRCP, just for, can you tell me how much protein a normal person needs, an ICU person needs, and how much person a CKD or non-hemodialysis, CKD or dialysis person needs? Is it more, not the exact value, is it more or is it less than a normal person? Okay, I should tell. In a normal ICU person, the normal protein requirement is around 1.2 grams per kg body weight. In a patient who is having a CKD, that increases to around 1.5 grams per kg body weight. And in a patient who is undergoing hemodialysis, you can increase up to 1.7 to 1.8 grams per kg body weight. The concept.
Sir, can you repeat?
You don't need this. I'm just telling it for your. Yeah. Anyway, of course I'm repeating. Normal person in an ICU, that is a non-CKD patient. By normal, I mean a non-CKD patient in ICU, requires around 1.2 grams per kg body weight of protein per day. A person who is suffering from CKD requires a 1.5 grams per kg body weight of protein per day. And the person who is undergoing hemodialysis for CKD, either you can give 1.5 or you can give it even a bit more, 1.7 grams per kg body weight per day. Why is it important? Is because previously the concept was, since the person is suffering CKD and dialysis, give less protein, less nitrogen, because the person is unable to excrete the nitrogen. But now the concept is, there is so much body protein loss in a CKD patient, even one who is not undergoing a dialysis, they need more protein than a normal person. And when a person who is on dialysis, so you're already removing the nitrogenous source body products, right? So give some more protein to that person. So the important thing is to remember is that give some more protein in addition to the one which you would give for a person in ICU, for a person who has CKD or dialysis. Even if you're not giving the exact 1.5 or 1.7 grams per kg body weight, give, suppose you wanted to give 60 gram protein for that person if that person was not having the CKD patient. Now try to give 70 grams, 75 grams, something like that. Very important to remember this. And this is in all the guidelines now, in the nutrition guidelines, in the CKD guidelines, in the KDU guidelines, everything. So it's an internationally recommended, internationally accepted thing. There is no personal choice, no nothing. If you're giving other than that, you are making a medical mistake. Nothing else. Anyway, 63-year-old woman presents with malaise, ankle swelling, shortness of breath. Her blood pressure is obviously very high. She has a +2 peripheral edema. Skin is tight and shiny. Fundoscopy discloses bilateral papilledema. Plasma creatinine 370. Potassium is on the higher side, 4.9, not beyond normal limits. Hemoglobin is low. Platelet count is this much. Read through this. I shall show the option of the latter part after this. I think
Scleroderma crisis.
Scleroderma, yes.
Crisis with high pressures and hypertensive changes. And
Yes.
these renal parameters.
And there is also fundoscopy changes.
Fundoscopy papillary.
Yes. This creatinine changes, hemoglobin is low, and platelet is okay. Okay, moving on to the next part. What is the pathological hallmark?
It is mucoid intestine.
I think this is the previous question. CD
Yes,
of.
It's a question, sir. We are just not. Yes.
I'm telling you the question.
These
are the options. This is the question. Okay, so what is the answer? Okay, everybody is going for C. Dr. Moshumi is going for option D. Option C is functioning adenoma of the adrenal cortex. Doctor, why does everybody think it's a functioning adenoma of the adrenal cortex? Or did I see the options wrong? Yeah, everybody is going for option C. Yeah, somebody tell me, why do you think it's a functioning adenoma of the adrenal cortex? What is the diagnosis? Everybody got a diagnosis right? The skin is shiny, the blood pressure is very high, fundoscopy is there. So it is a systemic sclerosis with scleroderma renal crisis. So scleroderma renal crisis, that is not it's not a tumor, right? It would not be a functioning adenoma or adrenal cortex.
I think what you have seen is only for the previous, sir. I think previous question.
No. Is it right? The previous question I'm seeing.
Yeah, everybody has written C. It's protein calorie malnutrition.
Okay. Sorry.
For this, I think only.
I was getting confused.
Okay.
Okay, then it's okay. Then it's fine. Yeah, I mean the option D is the answer here. The only reason I use was so that you guys go and study this renal crisis and the scleroderma part. It's a mucoid intimal thickening vascular endothelium classical. It is not a stenosis, it's not an RTA. I mean renal tubular. Sorry, this what do you call it? It's not a stenosis. Yeah, functioning adenoma obviously is not there. Autoimmune destruction, there is nothing suggestive autoimmune cause here. Aneurysm is found in scleroderma, but here the patient is suffering from renal crisis and everything, so they will be good intimal thickening vascular endothelium. Okay, so that I think brings an end to our sessions. Let's go through the questions and the options and the questions and a bit of underlying causes and those things. Those especially those which are coming more and more. These rheumatoid arthritis, SLE, and the scleroderma part. Then the post-arterial glomerulonephritis, IgA nephropathy. Then the renal stones, post-obstructive causes, cholesterol embolism, and the those sort of things which comes repeatedly. Nephrocalcinosis, then myoglobinuria, rhabdomyolysis, those things. And the bit of renal carcinoma, and those textile based questions, then cytosol based questions, which are typical MRCP questions. So revision is very key. I think you have to go through all the questions of these past medicine and past test, once, and then repeat at least one or two times on the other question bank. That I think is good enough for part 1 at least. Part 2, yes, a bit more revision, a bit more clinical improvement is needed. So thank you. I think that's the end of my classes. Don't have any
Thank you.
Thank you, sir.